Kia ora koutou katoa, no mai haere mai ki te manatu hauora. Welcome back after a bit of a break to the Ministry of Health. Thanks very much for coming up today. Well, as you will all know, we're nearing the end of New Zealand Sign Language Week. It's a celebration of sign language as one of our 3 official languages in Aotearoa, New Zealand. So I do want to take this moment to acknowledge and celebrate our deaf community across the motu and also pay a tribute to our interpreters here today. Just from me personally, I've particularly enjoyed working with our New Zealand Sign Language interpreters over the period of the pandemic, in particular at the 1 p.m. stand-ups. They do a fantastic job, and it has helped communicate information to a crucial part of our community. So I want to thank them so much for their work in this week where we're celebrating sign language. And I want to acknowledge Deaf Aotearoa, who have helped me this week participate in the Sign Language Challenge, and also who kindly donated this T-shirt to the Ministry of Health here. Here we go. And to celebrate Sign Language Week. And you might see right to my right a lovely clock that has got the numbers in New Zealand Sign Language symbols. So thanks very much for that to Deaf Aotearoa. So today I want to provide a bit of an overview and assessment of where the Omicron outbreak is at, and look ahead to the coming months, in particular winter, and what we can expect from both a COVID perspective and also an influenza and respiratory syncytial virus, or RSV, perspective. I'll just start with today's case numbers. We haven't done this for a while. They come out in the 1 p.m. statement every day, but today our number of new community cases is 7,441, and our rolling 7-day average, and this is the important number because you will see them fluctuate. They drop down over the weekend. Our rolling 7-day average today is 7,548, very similar to what it was last Friday, 7,555. The impact of Omicron, even though it's a less severe variant of COVID than Delta, the impact on in terms of the severity of illness is still visible, and we've got 398 people in hospital around the country today, and 6 of them are in intensive care or high dependency units. Sadly today also we're reporting a further 29 deaths with COVID-19, and so the total now comes to 940 deaths, and the 7-day rolling average is at 14. Now just a reminder that the number of deaths reported each day does fluctuate. We saw it, I think, 3 at one point one day over the weekend, a large number today, and on today's number 14 of these deaths are ones that we have found through a reconciliation of all the deaths that have been reported through the deaths document database over the last weeks and months. I mentioned a couple of weeks ago that we are also looking at how those deaths are categorised, and we're very nearly through that work of categorising all those reported deaths into those that were absolutely clearly from COVID-19, those where COVID-19 was a contributing factor, and those where it was incidental, but the cause of death was another cause of death. And we will be updating that, be able to update that on a daily basis once it's reported, because our coders are going to look at the data every day with a special workaround. So I do want to pass on my condolences, not just to the whānau and friends of those who have died that we're reporting today, but those who have died throughout the pandemic. So I want to move on and show a few slides to illustrate what is happening with the outbreak in New Zealand. First of all, and this is a slide we've shown before, and we will be able to make the slides available in soft copy afterwards if you'd like to either ask Luke, who's our media advisor at the back of the room, or email our media team. So this is cases per 1,000 people by our 4 regions, which are the northern region, what we call Te Manawataki, and the midland region, the central region, which is around Wellington and north of Wellington, and then the southern region, which is all of the South Island. Now, the important thing to note here is the orange line, which is the northern region, and you'll see that whilst it's not the highest at the moment, the highest rates at the moment are in the southern region, and we can see that in our case numbers and our hospitalisations, especially in Canterbury and in Dunedin, southern. But you can see the northern region case rates creeping up again over the last 2 or 3 weeks, and you'll have heard commentary about this. that does suggest that there is more infection again in the northern region. But I would say that alongside that, we haven't seen an increase in the quantity of virus found in wastewater testing in the northern region as yet. It's still level. And likewise, the positivity rate of people presenting to hospital, and everyone is tested when they're admitted or in the ED, the positivity rate is steady at around 5% across that northern region. So some of this apparent increase may well just reflect more people reporting. For example, if people were away over Easter and the Anzac period, they may not have been quite so inclined to or may not have reported infections, but now they are back home and we still have that isolation period of 7 days required. They are reporting there. We have got increases across in the number of cases in the 7-day period to the 8th of May. It increased in 7 of our DHB regions, Waitemata, Auckland and Counties Manukau. Modest, not the 50% increase that people have been talking about, and also in the Waikato and Hutt Valley and Wairarapa and Capital and Coast. So really centred around the northern region and Waikato and here in the capital, Wellington. We know that some cases are not reported, and we do try and estimate the level of reporting we think we're getting. And one of the best ways we can do this is look at the positivity rate of our border workforce who are undergoing surveillance. And based on that, we think that probably about half of cases, actual cases, are being reported. And some of those cases not being reported are because people don't have symptoms, so they're not actually testing. Others, the symptoms may be very mild, so people don't get tested, whilst others, of course, may be testing but not reporting the result. On testing, you will recall, and as part of our standard practice through the review, through the pandemic, we've reviewed our ongoing response, particularly when things haven't gone as they should have. And in March, I commissioned a review to look at the backlog of PCR tests that we had in the early part of the Omicron outbreak. And when we made that shift to rapid antigen testing, I've received that review, that external review. My team is going through it. We are developing up our response, and I will be speaking to both and releasing the review and our response to it in early June. Our second slide has got a few things in it, but what this is showing is our modelling of hospitalisations as we expected in the outbreak to date. And then the black line with all the dots is the actual hospitalisations and how that has mapped. And then it's looking forward to 2 scenarios that our modelling suggests could happen through winter. And I'll come on to those a little bit more. But the scenario A, the blue line, is a lower peak, perhaps delayed till around August, September, so later in winter. But the scenario, of course, that it behoves us to plan for is the second scenario, scenario B, which sees, and we may be seeing this, an increase in cases and on top of that hospitalisations through May, and then another quite large peak, another outbreak again through winter. We know that winter tends to bring more respiratory illnesses. People are inside more, and so there's more opportunity for the virus to spread. We can see, of course, that there has been a decline in hospitalisations, which peaked about where the modelling suggested, just over 1,000 on the 22nd of March. In the case of both cases, we thought our case numbers would come back to a baseline of around 3,000 to 5,000 a day. In fact, they seem to have bottomed out at around 7,500 a day, and hospitalisations have levelled off at the mid-300s. We can see today 398, maybe going up again. So it seems we've probably reached the nadir, the bottoming out of both cases and hospitalisations from this outbreak, and we may well be on our way back up again. And again, that scenario, the one we're planning for, scenario B, is potentially for another quite large outbreak in winter. I'll come back to that. I've got a couple more slides on that to show the impact of flu and RSV and COVID. But before I do that, just a quick summary of key international developments. In North America, we can see cases starting to rise again. It started on the East Coast, as have all their outbreaks, and moving across the country. And of particular interest is that the predominant, or the variant that is driving most of that increase, is the BA2.12.1 subvariant. And we have detected a few cases of that here in New Zealand, all having come from the USA. Now makes up 40% of cases in the USA, and their hospitalisations are also increasing again. It will be interesting to see just what sort of cross-immunity people who have been infected with earlier subvariants of Omicron have got against this new subvariant. South Africa we know about. It's seen quite a big surge in cases driven by the BA4 and BA5 subvariants. We've found a few cases of each of those here in New Zealand. And likewise, looking at the UK and Australia, they've experienced two quite distinct Omicron outbreaks, initially an early BA1 related one, which was in December, January, and then a BA2 related one in March and April. And each one having quite a significant increase in cases. New South Wales is following a similar pattern to New Zealand, and their cases have plateaued down again at a level maybe similar to ours, and that's driven by BA2 subvariant, as is our one. The important thing about this is we've got some early evidence about perhaps a slight transmission advantage for some of these newer variants, the BA4 and 5 and the XE variant, subvariant, and the others. But what we don't know yet is whether they cause any more serious disease than the BA2. The other thing that is emerging internationally is more information about the importance of vaccination in providing protection even if someone has had COVID. And there's a phrase that's been coined for this, describing this as hybrid immunity. And some studies that have been published recently that show that for people who have had Omicron infection, if they go on and have a booster dose after a delay, that affords a much higher level of protection than just the protection afforded by having been infected per se. So this is a very important message for the many people who have been infected over the recent months and who may not have had their booster. Yes, our advice is to wait 3 months, but it is absolutely worthwhile going in and getting that booster dose, the third dose, as soon as you are eligible for it, to help protect yourself from potentially being reinfected and, of course, protecting others around you. On the subject of reinfection, we've just provided some updated guidance to the sector around whether and how to test people who might be reinfected with COVID. There is a risk. It seems to be a small risk, but there is a risk of being reinfected with COVID within 90 days of a first infection. It happens rarely, and the guidance we've provided out to the health system is designed to support appropriate testing and management in that case. We're continuing to monitor both the international evidence and our own experience here around reinfection. And what we're really looking in particular at is whether these new subvariants are more likely to cause reinfection for people. But just to say again, all the measures that help prevent you getting infected in the first place will help prevent you getting reinfected. It is a risk, and so the usual things are very important. Get that booster if you haven't had it as soon as possible. Use masks when in indoor environments outside of the home, and of course stay home if you are unwell, whether it's COVID or not. Now, a little more on our winter modelling. We've passed the peak, it seems, of the current Omicron outbreak, but we are preparing, as that earlier slide showed, for another potential peak during winter, and that could be quite high. At the same time, we have been anticipating and are planning for concurrent infections with influenza. We're already finding some here, particularly down in the lower part of the South Island. They've found some influenza A. And it seems there's some in the student population in Dunedin and now also some in Queenstown. So we have some isolates. What we've seen in the Northern Hemisphere is that the flu and RSV seasons through their winter were quite low, but actually they've got a bit of a surge again now. And recently, Australia is finding some influenza A especially. The good news is, in Australia, where they're a little ahead of us, the current flu vaccine and the strains in it afford a good level of protection, particularly including against that influenza A. We know also evidence that people can be co-infected with flu and COVID at the same time. Around 3% of people, they have found this in the UK, and that people can be particularly unwell with that. So all the more reason to do everything you can to prevent yourself getting a respiratory infection, masks and so on, but also to have both a flu vaccine and be up to date with COVID vaccination. So on then to our winter planning. So what this slide shows is our typical winter, and what's modelled here is what happened last season, where that blue level of admissions to hospital around the country for respiratory illness, you can see it peaks during winter, and that's mostly because of flu. But on top of that, we've put that RSV peak that we experienced last year. It was really quite significant, and you'll recall how much pressure it put on our hospitals at the time. So we were expecting to see that. But what we've also done, and this is the next slide, is we've modelled that RSV peak, which we may see, with under the blue colour there, what we would expect from a normal flu season, and we've put our modelling of COVID-19 on top of that. And you can see when it really peaks in perhaps July or August, that's a pretty significant number of people in hospital with respiratory illnesses, including over 1,000 potentially at its peak with COVID alone. So of course, all our district health boards and nationally, we are doing quite significant planning ahead of winter and the potential for that surge. Flu vaccination is imperative here. We've already had approaching 700,000 people who have had their flu vaccine since we kick-started the campaign on the 1st of April. And particularly important is many people over 65, around half of our over 65s already, which is great. Please, many people are eligible for free flu vaccination. Go and get one if you're eligible for free flu vaccination. And even if you're not, please consider doing so. It's relatively cheap. We're also finalising our eligibility criteria and the detailed operational rollout for a 4th dose of the Pfizer vaccine for vulnerable groups, including older people. We'll have an update on that soon as final decisions are made, but I'll just make 2 comments. First of all, something that's absolutely guiding our decisions on this is our technical advice is to wait 6 months before that 3rd dose. And for the vast majority of people, they haven't yet reached that 6 months. And the second is, and this is particularly important for older people, we're very keen that they have peak immunity from that 4th dose right at the time of that winter peak, projected winter peak of Omicron. And that's not till July and August. So there's no hurry to get people that 4th dose, and we are wanting to get the timing just right. And June will be the time when we're aiming to roll out that program. But we'll have more on that when final decisions have been made and we can provide the detailed operational information. So finally, and then we'll have questions, the 3 things that I remind everyone to do, make sure you go into winter as prepared as possible. You will see from that last slide, it's still on the screen, our health system will have a heavy load of respiratory illnesses through winter, and everybody can do their bit to help reduce the impact of that potential load by being up to date with all vaccinations, and that includes for young people and children, MMR, as well as of course flu and COVID-19. Secondly, wear a mask. Good rule of thumb is outside of home, any indoor environment, wear a mask as much as possible. And finally, and this is really important and why we're still recommending an isolation period for cases and household contacts with COVID-19, is stay home if you're unwell. Test, get rapid antigen tests, and then report your result, whether it's positive or negative, to all those who have done so and continue to do so every day. Thank you very much. It's absolutely important for our planning. So I'm happy now to take questions, please. Yep. So just to rehearse, I mean, the comments are made. Some of this I think is real, is no doubt, because we are seeing hospitalisations go up a little bit. But we're not seeing an increase in positivity rate of people turning up to hospital. So everyone, for whatever reason, going into hospital gets tested, and that's staying steady, as is the wastewater testing. So some of that apparent increase may just be an increase in both testing and reporting of testing.
And speaking of testing, I mean, so with the reporting of their results, are people reporting them? I mean, how great is the underreporting?
Yeah, so the first comment I would make is I'm actually really impressed with the number of cases that have been reported. 7,500 cases every day. These are people who are not just doing the test, but are reporting them. And about half of our tests that are reported, our rapid antigen tests, are positive. So we've got another 7,000 or 8,000 people every day reporting their negative results. This is impressive, and it's absolutely essential and important, so I want to thank people for doing that. Our estimates are that there's probably about as many cases again out there that are not reported, although some of those it's because people are not symptomatic, so they're not testing. But for those people who are testing, yeah, please do report your results.
Would you reconsider your resignation if there was another big outbreak?
I'm confident that we've got in the system, we've got the people, the processes and all the services in place to deal with another outbreak. Indeed, I won't be reconsidering my resignation, but thanks for the question.
Dr Bloomfield, if the flu jab is so important, why can't it be free for everyone like COVID jabs?
That's something that we've considered and talked about with both pharmac and ministers, and you will have seen this year that actually the groups who can access it for free have increased, and that includes now all Māori and Pacific people from 55 over. So there's quite wide access to it for free, and actually if we could get more people who are eligible for it for free to get vaccinated, particularly in our Māori and Pacific communities, that would be hugely valuable. Likewise, many employers, of course, provide it for free or a heavy subsidy for their employees. And I've actually sent a message out to employers to encourage them to vaccinate their staff ahead of winter.
What percentage of the population is eligible for a free flu shot?
Well, you've got me there. I'll have to come back exactly on that. But it's the important thing is it's not just a significant proportion, but it's the people who we know would have the worst outcomes if they did get the flu, and so that's who the free vaccination is focused on.
Do you personally think that it should be universally available for free?
Well, it's certainly universally available, and I encourage everybody to get it. We've had a look at whether to provide it for free for everybody, and at the moment I'm really pleased that we've had that extension of eligibility for free vaccine this year.
So is the reason it's not universally free for financial reasons or epidemiological?
It's more for epidemiological reasons.
How is the border reopening affecting the model? Like, last winter our borders were shut. This year we've got people come in. You just spoke about how that variant is spreading through the states. They're all going to come here with no pre-departure testing. How is that affecting the modelling?
Well, of course, we still do have pre-departure testing at the moment, and we then have and intend to maintain a requirement for everybody coming in to be provided with rapid antigen tests, to do the testing twice and to report that test result. And then, of course, we can keep our surveillance going for those new variants. And those people that do test positive, who have arrived recently, are required to isolate for that 7-day period. So that maintaining that isolation requirement for cases is absolutely fundamental to our ability to control the outbreak in New Zealand, and including any onward flow of any new variants that might come into the country. Many countries don't still have that requirement for either testing on arrival, which is much more important than actually pre-departure testing. But at the moment, of course, we still have got the latter in place.
What if any initiatives or events have the health officials planned to encourage an uptake in boosters?
Yes, this is vexing us. We have been pushing this for quite a while, very hard, with advertising, and all the infrastructure is still out there to get booster rates up. I should say our booster rates have levelled off at almost identical rates to what other countries that had very high initial course rates. So it seems to be an issue internationally. We're looking at that, and in particular how we can get those rates up, and our paediatric vaccination rates up, which aren't at the level which we want and we're hoping for. So our approach now is this one of really positioning it around getting ready for winter. and includes a range of things, including flu vaccination.
Would there be a Super Saturday type event?
We haven't planned for that, but of course we'll keep every option on the table.
How many of the current cases are kids who caught COVID at school since the holidays?
I don't have that information. What we will be able to do is provide a breakdown, and it may be in the 1 o'clock statement, of the age breakdown. At the moment, still the majority of cases are in our younger age groups. So when I say that, sort of under 35s, for those of you who are in that age group, you're still young. But the fastest increase in rate is in our older age groups, and that's why I think we're seeing our hospitalisations start to go up again.
On the updated vaccination passes, there was the second point made around how if you've been infected but haven't had your booster, you can still get a vaccine pass. How much is that an honesty system? So if they need to get brought back, how much is that relying on people to do the right thing and say they have been infected when they could just lie?
Well, the easiest way for us to know that people have been infected is they've recorded a test, a rapid antigen test online. So for most people that will be the case, so we will be able to verify. There will be some people who have been infected, did a rapid antigen test, maybe didn't upload it or didn't test, and of course that will require an honesty system, but there will be a process that we will make public over the next couple of weeks as to how they can get a temporary vaccination pass until they're due for their booster, which will be 3 months after their second dose. 3 months after their infection.
And the Disability Commissioner found that the disability community did feel quite left out in a lot of previous decision making. How much engagement are you going to be doing with them going forward in future decisions?
Yeah, what I would say is that, and I've looked at the report from the Disability Commissioner and our response to it. The majority of those issues that were identified, we had already started engaging with much more robustly and also appropriately with the disability community. So I'm confident that our engagement with the disability community around care in the community model, around vaccination and around the broader response is much stronger than it was certainly early on, and those were the issues that the disability community rightly pointed out we could have done better on.
And on the...
Yep,
I
please.
was going to go back to Auckland, if that's okay, around that. I guess the increase in cases now, are you concerned that we're kind of going to see the second wave much earlier than one day?
It's possible, and I'll just go back to that slide there where you can see one of the scenarios that's been modelling is showing a possibility of a sort of another smaller surge during May and then dropping down again before that peak. It's too early to say, but this might be what we're seeing, and of course if it does happen we will likely see it in Auckland first.
I was just going to say, are we seeing any, or are you aware of any kind of staffing issues at present in the Auckland hospitals due to infection?
So the staffing issues are less severe than they were right in the middle of the big early outbreak in Auckland and indeed around the country. But the issues caused by the outbreak were on top of kind of existing staffing pressures. So this is one of the key things that, as part of the DHB plans for winter, is working out how they will anticipate staff absences, maybe of 10 to 15%, and work out how they will redeploy staff, not just inside the hospital, but potentially out into aged residential care to support aged residential care if their staff members have to stay off work as well. So that's a really fundamental part of the planning.
Dr Bloomfield, back in March, it was reported that doctors and health service providers were trying to get more guidance about long COVID.
Yep.
How much progress has been made with that, and what support is currently available for people with long COVID? Some have reportedly been having a lot of trouble getting help for free. Yes,
so this is clearly an emergent area, both our understanding of long COVID and indeed then what can be done to support and help people manage their symptoms. We've got a good stream of work on this, and we did a briefing on it I think about a month ago. I had Dr Ian Town here who talked about that. I would like to, if it's okay, be given the opportunity to get an update, and perhaps at the next briefing I can have that as a bit of a focus on what else we are doing to support people with long COVID and indeed what specific services are available to them, including those which they may or may not have to pay for. But we are absolutely working on this.
I mean, given that this issue was raised more than 2 months ago, how satisfied are you with that rate of progress? It sounds pretty slow.
No, I'm satisfied with our progress. I just would prefer if I had a bit more detail and I could give a bit more information about that.
The government's been making a lot of decisions around reopening New Zealand. How satisfied are you that they're still taking your advice? Obviously, this is the first time we've been able to talk to you for a while. Are you satisfied they're still following the best health guidelines, or is it becoming more economical?
Well, right through the pandemic, my advice has been considered alongside the advice of other colleagues. And of course, the public health advice has been a central part of our response. And it remains so. So I can say that we still have weekly meeting with colleagues from across government, with the Prime Minister and senior ministers, to discuss the full range of issues. And much of the advice that is going into the Reconnecting New Zealand program is coming out of this ministry. It's around issues like testing at the border, testing of the workforce at the border, vaccination requirements, and so on. So I'm really confident that our advice is still very much front and centre in the decision making, not just by ministers, but also by my colleagues across government as well. Any final questions?
Just going back to long COVID, so for people who have symptoms, for people who may have long COVID now, and WHO said that 10 to 20% of people who get COVID might get long COVID, what advice do you have for them right now? Because there could be tens of thousands of them, maybe more in New Zealand, who have long COVID. What should they do if they're trying to get help?
Well, most importantly is to seek that help through their usual health provider, and that would most likely be a general practice or a primary care provider. And I can say that increasingly those providers have got better information all the time about what the symptoms are, how to manage those symptoms, and indeed what supports are available. And we've got a stream of work here led by our Chief Allied Health Professions Officer, because a lot of the support and follow-up for people will be in the rehabilitation area. It's not about specific treatments per se.
So how expensive do you think long COVID will be to our society? It sounds like it may potentially have quite a lot of long-running costs to the economy and society.
There could be, and that's all the more reason for people to continue to try and avoid getting COVID, and certainly if you do have it, to rest up. Thanks very much. Really appreciate the session today. Go well.
Yes.